Good morning, everyone. So thank you very much for your time. Basically, over the next 35 to 50 minutes or so, we'll basically spend some time going through the structure of the platform trial quite briefly, and then really focus on the invasive mechanical ventilation domain and the drive RCT in particular. So the practical platform is a relatively new adaptive platform trial studying acute hypoxemic respiratory failure, which, as you know, is a very common and serious condition for which patients are admitted to the intensive care unit. It has a range of causes and has substantial morbidity and mortality, and includes more specific entities like acute respiratory distress syndrome. But we're taking quite a pragmatic approach to the definition of hypoxemic respiratory failure for this platform. Um, because patients with hypoxemic respiratory failure are vulnerable to a range of nosocomial complications, in particular issues like lung and diaphragm injury, the platform's focused on essentially trying to optimize supportive care management. So some of the interventions that we're studying are novel ventilation strategies, including extracorporeal life support, as well as we're interested in studying interventions like sedation and other pharmacological strategies for managing respiratory failure. And we basically see this as an immense opportunity to improve and define care for patients. There's many therapeutic opportunities, and as yet they remain unstudied. And so we hope that practical will be a means of accelerating discovery in this space. Next slide. So we are running multiple trials, which are structured as domains. These domains incorporate trials at the pilot, phase 2, and phase 3 stage, looking to improve outcomes for patients with respiratory failure. And the overall primary objective is to test the feasibility and efficacy of interventions, looking at both surrogate endpoints and short-term and long-term patient-centered outcomes. The master protocol governs the overall conduct of the trial, and that contains a lot of generic information, the overall design of the trial, how the trial is governed and administered, et cetera. So you can refer to that at your convenience. So the way that the platform functions is that there are kind of broad eligibility criteria defining the platform trial population. And then each domain has additional criteria that limit to a specific domain population. So we have platform eligibility criteria and then additional domain-specific eligibility criteria. So these are the platform criteria. We're basically defining hypoxemic respiratory failure as new or worsening respiratory symptoms developing within 2 weeks prior to the onset of need for oxygen or respiratory support. That type of respiratory support can be any really type of oxygen or respiratory support required for at least 4 hours. So supplemental oxygen at 10 liters per minute or higher, high flow nasal oxygen, non-invasive ventilation, invasive ventilation, extracorporeal life support. So we're looking at a range of severities, but we basically say a patient requires any of these supports has hypoxemic respiratory failure. And the minimum oxygen requirement to meet our definition is that the FiO2 is at least 0.4 and the oxygen flow rate is at least 10 liters per minute for at least 4 hours. We're studying adults, so the age restriction is to greater than or equal to 18 years. Next slide. The exclusion criteria basically try to rule out patients who don't have hypoxemic respiratory failure due to parenchymal lung injury. So if your hypoxemia is likely from heart failure or volume overload, if it's attributable primarily to pulmonary embolism, or if it's mainly from status asthmaticus, then you would be excluded from the platform population. So this is kind of our pragmatic way of getting at ARDS. We don't require bilateral airspace opacity, so that's an important difference from the ARDS definition, but otherwise we're sort of after causes of hypoxemia related to parenchymal lung injury. Patients are also excluded if extubation is imminent or if ICU discharge is imminent or if death is imminent and or the patient's being transitioned to a palliative philosophy of care. The platform defines severity states based on a range of characteristics. One of the most important is the respiratory system elastance. And we believe this is important because it defines the risk of ventilator-induced lung injury based on available data. So patients are defined in 4 basic severity states, so non-intubated, intubated, or on ECMO. And then the intubated patients are divided into patients with low respiratory system elastance or high respiratory system elastance. And the states are important to us because we think that treatment effect may vary between states. And so we think this is sort of relevant for defining more precise estimates of treatment effect to guide evidence-based medicine. Next slide. The platform's grown tremendously over a few years. We've been able to build a large network in Canada and the United States. We have sites in South America that will be joining, sites in Spain that are active, sites in Italy that are active, sites in Ireland that'll be active soon. We have sites in Saudi Arabia, elsewhere in the Middle East. And then there are sites participating in Asia as well, Singapore, Australia, and New Zealand. So it's a big global partnership, very exciting to be working together with people around the world. And we're hoping that over time, this platform will serve investigators well from around the world. Okay, next. Okay, perfect. So now we're moving into the, not so much talking about the platform globally, but the invasive mechanical ventilation strategies domain specifically. So this domain is an adaptive platform RCT in its own right. We're studying multiple novel invasive ventilation strategies in comparison to the standard control group of conventional lung protective ventilation. And essentially what we're aiming to do with this domain design is to identify interventions that are the least effective and should be dropped, and the most effective and should be kept in the trial. And over time, hopefully help to improve care for patients enrolled into the domain. We're also actively investigating how treatment effect might vary between subgroups, and so a lot of interesting analytical and methods development, exploring how best to account for differences in subgroups as the trial proceeds. The overall arching objective of this domain is to establish which ventilation strategy most effectively improves outcomes. But secondarily, we're interested in establishing feasibility and tolerability of novel strategies, looking at protocol adherence and safety, and also defining physiological and biological effects, especially for phase 2 trials. So we hope that the domain will function as a pipeline for the discovery of constant improvement in mechanical ventilation management. Next slide. So this is the current structure of the domain. We have 4 arms. So patients who are eligible for practical and then meet eligibility criteria for IMV, which we'll talk about in a moment, can be randomized to any of these arms, depending on what site they're at. So if some sites are enrolling patients to all 4 arms, some to just to 3, and most to just to the first 2 arms, the LPV or lung protective ventilation, which is the control group, and then DPL or driving pressure limited ventilation. And those are the 2 arms that your center will be enrolling into. And those 2 arms together constitute what's called the DRIVE RCT, which is a large phase 3 trial looking at a primary outcome of ventilator-free days to day 28. Next slide. So as I just mentioned, the primary outcome for DRIVE is ventilator-free days to day 28. It's structured on an ordinal scale. Death is classified as -1. And then days alive and free ventilation up to day 28 are scored, and that becomes your final outcome. Next slide. Secondary endpoints in the domain include survival, in the platform as a whole. No matter what domain you're in, these outcomes are collected. So hospital survival, ICU discharge, ICU survival, and survival to disconnection from mechanical ventilation. We're looking at the duration of ventilation and the length of stay in the ICU, ventilator-free days to day 28, transitions between states. So a transition from, say, intubated to ECLS, and then serious adverse events as defined in the domain protocol. So those are collected in every domain. Specifically in this domain, because it's focused on ventilation strategies, we're collecting outcomes including reintubation, tracheostomy, need for ICU readmission, the duration of hospitalization, where patients are discharged. We're also looking at all-cause 60-day mortality, barotrauma during the ICU admission, cardiac arrest during the ICU admission, and then long-term outcomes, including survival to day 180 and hospital-free days. We are collecting a number of physiological and organ function endpoints during the trial as well. So the SOFA score and some basic respiratory mechanics and gas exchange measurements. This is an interesting trial to be involved in that it's an adaptive trial. The sample size is not fixed. And so the stopping of the trial will be determined based on the results of pre-specified interim adaptive analyses. We have basically stopping rules that are checked at each interim analysis as more patients are enrolled and this trial statistical model gets updated. And if the trigger for superiority is met, then the trial would stop, or if the trigger for futility is met, the trial will stop. Next slide. This is a little bit more detail on the adaptive design features. So we designed the trial so that we'll enroll a minimum of 500 patients in the low elastin state and a minimum of 500 patients in the high elastin state. The maximum sample size to be enrolled in each state is up to 2,000. And once we hit that minimum of 500, we'll start doing adaptive analyses every 3 months. And the superiority trigger to reach a conclusion to stop the trial is the probability that the odds ratio for ventilator-free days greater than 1 is over 99.5%. And the futility trigger is the probability that the odds ratio is less than 1.2 over 95%. And just so you have a feel of what this sort of how we expect it to play out, we do, when you do an adaptive design, you do extensive simulations, and with these stopping criteria and this design, we have a type 1 error rate that's well controlled. We have pretty high power, and you can see the power basically shown in the green here across a range of different treatment effects. So we expect that if there's no effect at all of this intervention, we'll probably reach a conclusion somewhere between 700 to 900 patients in each state. And if the odds ratio is 1.3 or higher, we'll likely stop at around 800 to 900 patients per state. So this is just to give you a feel. Of course, it's unpredictable, but this is what the simulations suggest we'll find. All right, so with that background in place around how the trial is designed, let's talk about the patient population in the domain. So we're in this domain, we're enrolling patients who are intubated, but not on ECMO at the time of eligibility assessment. And then some sites are enrolling patients on ECLS at the time of eligibility assessment, depending on which interventions they're randomizing to. So one of the arms can include patients on ECMO, whereas the other two intervention arms can't. And so because the DPL arm that you'll be randomizing to at your site does not include patients on ECMO, then you don't have to worry about enrolling patients on ECMO at your center. But you will be enrolling patients who are intubated, not on ECLS, with either low or high elastids. Next slide. So again, it gets pretty complicated pretty quickly when you've got a lot of arms with different eligibility criteria. But just for the sake of clarity, if you look at this figure on the left, what you can see is that at your site, patients will be randomized to either DPL or LPV. And this is the same whether they're in the low elastin state before randomization or the high elastin state before randomization. And we'll talk a lot more about how elastance is assessed as part of the trial and the randomization process. So the inclusion criteria are intubated and not on ECMO at the time of eligibility assessment. And number 2, the patient has confirmed hypoxemia, defined by a PF below 300 on the most recent blood gas, an SpO2 below 97 on an FiO2 at or above 40%. If a blood gas is not available, or for the LDPVS sites, a patient is on ECMO. Next slide. The patients are excluded from this domain if they have chronic hypercapnic respiratory failure, if they are on mechanical ventilation at home permanently, if there's an imminent plan to institute VV ECMO in the next 24 hours, if the anticipated duration of mechanical ventilation is less than 48 hours from the time of eligibility assessment, if the duration of ventilation during the current ICU admission is greater than 72 hours. So we would exclude patients who've been on the ventilator for longer than 72 hours because we want this to be an early intervention. And then we would exclude patients who have a previously diagnosed neuromuscular disorder. Patients who have who are mainly on the ventilator for severe acute brain injury are excluded. If the baseline weight is very low, if they're on ECMO but not on mechanical ventilation, then they would not be eligible. Additionally, if they have features like a bronchopleural fistula or severe liver disease, or if they've been randomized in the domain in the last 12 months, those are all exclusion criteria. Okay, so your patient meets eligibility criteria, doesn't meet any exclusion criteria. You approach the patient, the family consents for participation, and so the next step is to get the patient randomized. So how does this work? Well, in this trial, because as I've already emphasized, elastance is a very important potential predictor of treatment effect. We want to measure the elastance at baseline before randomization, and the randomization is stratified based on the measured elastance. So it's a critical measurement. Basically, in this trial, elastance functions like a predictive biomarker of benefit or harm from the treatment effect, much like, say, subphenotype and ARDS people talk about. So it's really important to get the measurement right. Now, when people talk about elastance, they're much more often more familiar with talking about compliance, which is just the inverse of elastance. So they're really the same parameter, essentially a measure of how stiff the respiratory system is. And in order to make that measurement in a valid and reproducible way, we, in the protocol, apply standardized ventilator settings. So these standardized ventilator settings involve the use of either volume or pressure targeted modes. Note that pressure support is permitted as well. If a patient's breathing, they can still have their elastance measured and be randomized. I'll discuss that in a moment. So patient can be in pressure, volume control, pressure support, and the measurements can be done. The ventilator support is adjusted so that the total volume is 6 mils per kilo or as close as possible. The PEEP is adjusted to be 10. It can be higher if needed to maintain adequate oxygenation, or lower if the plateau is too high. The respiratory rate is adjusted to maintain an adequate pH, and then the FiO2 is adjusted to maintain adequate oxygenation. So after applying those settings for 30 minutes, then we're going to perform the pre-randomization assessments. And there's essentially 3 pre-randomization assessments. First, a measurement of airway opening pressure. Second, the measurements required for assessing elastance. And then thirdly, if the patient has an arterial line in place, we'll check arterial blood gases as well, so that we have a baseline PF ratio. Okay, so to support these measurements, because we recognize there's a bit of complexity to doing this, we've created, I just want to say before I get into the details here, as training materials that I think are really helpful. So we have a manual procedures on respiratory mechanics that people can refer to. We also have created very short training videos. They're posted on the platform website so people can refer to them. And then, as I mentioned in a moment, there's a QR code that is printed on the card that hangs on the side of the ventilator that you can hang on the side of the ventilator if you want. And that rapidly pulls up the training videos so that people can see how these different measurements are done on the ventilator that they're using. So the idea with airway opening pressure is essentially that in many patients at PEEP, the airways are closed, and that initially when you apply pressure to the airways, you don't get much inflation because there's a certain critical threshold of pressure that needs to be reached before the airways open. And the reason that's important from a mechanics point of view is that sometimes that can mean that the actual stiffness of the lung is actually much lower than it looks like because the airways are closed during a portion of inflation. So to measure elastance properly, we want to measure the airway opening pressure. So the way this is done is depending on the ventilator you have, you can put the patient into a mode with a slow flow inflation maneuver. You can see the kind of critical threshold and pressure, an inflection point where inflation actually really begins as pressure goes up. And that allows you to identify the airway opening pressure. This can also be done with the pressure volume tool that's available on a lot of ventilators. So I defer to you about how you want to measure this at your site, and hopefully it's relatively easy for the RTs to do this. Next slide. So now I want to talk a little bit about why we're so concerned about POC in this trial and how the POC measurement works. And so if you're already doing this, you're already very familiar with this physiology. So I'm just going to breeze through this fairly quickly. But the basic idea here is that in reality, when a patient's breathing on mechanical ventilation, there are actually two ventilators. There's the mechanical ventilator, and then there's the patient. And the mechanical ventilator is applying pressure to the lung, but so is the patient's respiratory muscle pump. And, traditionally, we've really only paid attention to what the ventilator is doing to the lung, but we think increasingly that it's important to pay attention to what the patient is doing to the lung as well. And so we want to measure the pressure being applied to the lung by the patient. And you remember that the overarching goal here in this trial of limiting driving pressure is to limit the stress applied to the lung. So when we think about driving pressure, we're not only thinking about the pressure from the ventilator, we're also thinking about the pressure from the patient. And in some patients, this can be important because if you look at the waveforms here on the right, the airway pressure swing is only about 10 centimeters of water, but the esophageal pressure swing is about minus 30 centimeters of water. So most of the pressure distending the lung here, the transpulmonary pressure swing of 40 centimeters of water, is actually really coming from the patient rather than from the ventilator. So we think it's important to pay attention to both. And that's the utility, as you know, of measuring the POC. Okay, next slide. So the POC, again, you're already familiar with this as you're doing it, is gives you a way of seeing the patient's effort by applying an expiratory occlusion. And when the airway is occluded, you'll see the airway pressure swing generated by the patient against the occluded airway. And that allows you to estimate the magnitude of the esophageal or pleural pressure swing during spontaneous breathing. And that becomes very useful because if we know the pleural pressure swing, then we can add that to the airway pressure swing to estimate the total lung distending pressure. And then we use that as a target in this trial when the patient's breathing. Okay. So the math is not that complicated, but I want to say the good news is that in this trial, nobody has to do any math and nobody has to do any calculations. And we've really worked very hard to make this as simple as possible. So first of all, the CRF, where the values get entered, especially immediately before randomization, does all the math computations automatically. So you don't need to worry about doing any computations. Secondly, you'll see that we have an app that's basically provides bedside decision support to help the RTs who are making the measurements follow the protocol. And that, again, automatically does all the calculations so that you can easily just get guidance on what the protocol requires through the app rather than having to refer to the protocol all the time. And so again, that avoids the need for math. But essentially, the esophageal pressure swing is about 2/3 of the POC. The airway pressure swing is obviously the peak minus the PEEP. So if you add those things together, you get the total lung distending pressure. Next slide. So as I mentioned, the QR code that's printed on the cards will take you to the instruction videos, and these are all very short. They're about a minute in length. There's instruction videos describing how you apply the protocol for a given intervention. There's an instruction video about how you do the baseline assessment before randomization. And we've tried to make it so that you can refer to these rapidly in real time. Let's say you go for a couple months without enrolling a patient. That way you can quickly remind yourself of what's required. Next slide. All right, so with all that kind of physiology and measurement information sort of in place, how do we actually measure elastance? Well, if the patient's not breathing, they're passively ventilated, you measure the POC and it's 0. So if you do an occlusion maneuver and nothing happens, then we call that a POC of 0. And in that case, we use the static mechanics. So that would be the driving pressure, plateau pressure minus PEEP, divided by the tidal volume in mils per kilo. And if the value's at or above 2.5, then the patient's classified as having high elastance. If it's below 2.5, then the patient's classified as having low elastance. If, on the other hand, the patient's breathing and the POC is less than 0, so they have a negative pressure swing during inspiratory effort, then we measure the dynamic elastance, because we weren't confident that plateau pressure could be measured reliably in these patients. So we measure the dynamic lung elastance instead. So here, it's the lung distending pressure computed, like I talked about before, divided by the tidal volume in mils per kilo. And because it's a dynamic pressure and incorporates a resistive component, the threshold for high dynamic elastance is higher. So that if it's at or above 3.5, then the patient gets classified as high elastance. And if it's below 3.5, the patient gets classified as low elastance. And then that's how they're randomized accordingly. Again, you don't have to do any of those calculations yourself. The CRF will do them all automatically. If you put a POC of 0 in, it will automatically use the static elastance. If you put a POC of -5 in, it'll automatically do the dynamic elastance and assign everything. Again, the app, I don't know, have you guys had a chance to look at the app at all already, just to get a feel for it? Looks reasonably comprehensible to use?
Yes.
Okay, super. So yeah, hopefully that'll be a very useful tool to make it easy to implement the protocol at the bedside. Okay, next slide. All right, so once the patient's randomized, we want to talk about now how the intervention, the protocol in each arm is designed. So the usual care or control arm is conventional lung protective ventilation. And this will be the ventilation strategy that's very familiar to you, because it's basically consistent with current best clinical practice according to ATS guidelines. The protocol is basically designed on the ARDSNet ARMA trial with a few slight modifications based on the way things were done more recently. And I would emphasize that we don't actually specify a PEEP titration strategy in this arm. We would invite you to use your usual site practice. And that's basically grounded in the fact that the management of PEEP remains somewhat an area of some uncertainty in hypoxemic respiratory failure. Okay. The mode of ventilation is either pressure targeted or volume cycled ventilation. So basically this table outlines how the ventilator is supposed to be set to follow the LPV protocol. So you have flexibility about the mode according to what you normally prefer to use at your center. I know many American centers prefer volume control initially or before transition to pressure support. Others use pressure targeted modes. But regardless of the mode, the tidal volume, the ventilator support should be adjusted so that the tidal volume is initiated at 6 mils per kilo. And I really need to emphasize this, maintained as close to 6 mils per kilo as possible. We do allow the tidal volume to range between 4 to 8. But that's really only under specific circumstances that it should deviate from 6. So you keep it at 6 as much as possible. When the patient transitions to pressure support, the pressure support is to be adjusted so that the tidal volumes are around 6 mils per kilo. And if your patient, by the way, ends up on ECMO for some reason, I don't know if you do have patients who end up on ECMO, but if they do, then we modified the control group management here to allow much lower tidal volumes if the lung is basically closed. As you know, the tidal volumes can sometimes be very, very low in patients with severe ARDS on ECMO. So we have that exception for ECMO patients. But otherwise, we really want to keep the tidal volume 6 mils per kilo. And adherence to this target is kind of critical for the experiment to work. Because if the driving pressure strategy actually allows tidal volume to increase in some patients, we're only going to see the effect of that if the tidal volume is maintained closely at 6 mils per kilo in the control group. The plateau pressure target is 30 centimeters of water. The pH target is greater than 7.15. That might be a little lower than what people are used to, but it's actually based directly from the ARDSNet-ARMA protocol. The respiratory rate target is at or below 35 breaths per minute. And then the PEEP, as I said, is adjusted according to local site practice. And the oxygen saturation is adjusted to maintain a saturation of 90% or more. In terms of monitoring, the plateau pressure should be measured at each routine ventilation assessment. In many ICUs, that's about every 4 to 6 hours. So, at each routine ventilation assessment, you'd measure the plateau pressure and make sure the patient's on target. Although in the CRF, we're only recording it once in the morning and once in the evening. So the data collection is less than the sort of clinical protocolized monitoring. We'll also be recording the driving pressure twice daily because we obviously want to know what the driving pressure is in both groups. And the POC will be recorded twice daily as well. But neither the driving pressure nor the POC are used to set the ventilator in this arm. Next slide. So I already emphasized trying to stick at 6 mils per kilo. And then patients who have and then the plateau pressure should be kept at or below 30 centimeters of water. The plateau pressure should basically be measured when the patient's passively ventilated without patient effort. So if they're in volume control or pressure control, they're not breathing, the POC is 0, then you can measure a plateau pressure. And the way we measure the plateau pressure is we apply a brief occlusion for about 0.5 seconds. And if there's no signs of breathing or expiratory muscle effort, then the plateau pressure would be recorded at that 0.5 second mark. If the patient's spontaneously breathing in any mode, then the plateau pressure doesn't need to be measured. All right, so the protocol provides for a number of scenarios that can arise. So for example, if a patient has severe respiratory acidosis, you can increase the respiratory rate up to 35. And if they still have a severe respiratory acidosis, then you can consider administering IV bicarbonate. You can also consider increasing the tidal volume in 1 mils per kilo increments as necessary to maintain a pH above 7.15. If the driving pressure is above 15, no adjustments are necessary or permitted. If the plateau pressure is too high, above the target of 30, then the tidal volume can be reduced in 1 mils per kilo increments down to a minimum of 4. And again, the respiratory rate can be increased to facilitate that. If reducing the tidal volume doesn't achieve that target, then the PEEP can be titrated as well to try and achieve a plateau pressure of 30, obviously monitoring the impact on oxygenation. Again, no adjustments for lung descending pressure. And in this group, basically, we encourage guideline-based sedation targeting a SAS of 3 to 4 or a RASS of -2 to 0 according to your usual site practice. That's essentially the control group. Okay, so then we come to the intervention group, the driving pressure limited group, or DPL. So the modern era of tidal volume limited lung protective ventilation has really been with us for about 2.5 decades now. And since that time, there's been a number of, I think, emerging insights that suggest that maybe there's a way to be even more lung protective. and that's to focus on driving pressure rather than on tidal volume. Next slide. We think there are patients who are at risk of residual ventilator-induced lung injury, even when you limit the tidal volume to 6 mils per kilo. And these are patients in whom the respiratory system elastance is high. So if the elastance is high, the lung distending pressures or the lung stress can be high, even when you reduce the tidal volume to 6 mils per kilo. And that's because the baby lung is so small that it's still at risk of overdistension. On the other hand, when elastance is low and the patient has a relatively large lung volume, then reducing tidal volume to 6 mils per kilo might actually not be necessary. And you could imagine that we actually end up suppressing respiratory drive and effort with sedation just to achieve our lung protective targets. And so if the tidal volume is actually, or if the elastance is low, perhaps we can actually liberalize tidal volume, and that might allow those patients to breathe earlier and to be liberated from the ventilator faster. And, a new technique, this occlusion pressure, allows us to monitor the breathing effort. And so we can see what's going on during assisted ventilation. A number of observational studies have pretty consistently demonstrated the outcome relevance of driving pressure over tidal volume. Amato's classic study demonstrated that across, even within fairly constrained ranges of tidal volume, the driving pressure appeared to be associated with mortality. And Martin Erner and colleagues demonstrated a persistent association between driving pressure and mortality over time. Next slide. And then more recently, we demonstrated that the effect of lowering tidal volume in the higher versus lower tidal volume ventilation trials, the treatment effect in those trials actually depended on the baseline respiratory system elastance. When elastance was low, there was really no difference in mortality, suggesting that maybe you could actually liberalize tidal volume in those patients. And when elastance was high, there was a relatively large mortality benefit, suggesting that maybe even further decreases in tidal volume could further reduce the risk of mortality in those patients. And that's really the basis for the design of the trial. Okay, so in pressure targeted or volumes, so in this arm, here's how the ventilator should be set. So again, mode of ventilation is up to you, pressure targeted or volume cycled modes according to your preference and usual practice. But regardless of the mode, the tidal volume needs to be set as follows. So in a controlled mode, with a POC of 0, the plateau pressure is measured and the tidal volume is adjusted to ensure that the driving pressure is at or below 15 centimeters of water. In an assisted mode, with the POC is less than 0 and the patient's breathing, the tidal volume is adjusted, targeting a lung distending pressure of 23 centimeters of water or less. And again, because that dynamic transpulmonary driving pressure is a dynamic pressure, it incorporates a resistive component. The threshold for safe is higher than it is for the static driving pressure. So we have some physiological evidence suggesting that 23 is sort of the equivalent of 15 during spontaneous breathing. And so that's where that number comes from. We allow a slightly higher plateau pressure target of 35, a pH target over 715. We allow a higher respiratory rate of up to 40 breaths per minute in this arm. And then again, the PEEP is adjusted according to local site practice. The FiO2 is adjusted to maintain an oxygen saturation at or above 90%. And the plateau pressure is measured at each routine ventilation assessment every 4 hours. So a couple of differences in this arm. The driving pressure should be assessed at each routine ventilation assessment because you're using the driving pressure to set the ventilator. The POC should be measured at each routine ventilation assessment. Again, we're only recording these values twice a day in the CRF, but in this arm, we want to monitor these values routinely because we're using them to set the ventilator. And then the lung distending pressure is again computed at each routine ventilation assessment using the app, and that is used to guide mechanical ventilation. Again, if the patient develops a severe respiratory acidosis, you can consider administering IV bicarb. if the pH is below 7.15 and the respiratory rate has been maximized up to 40, you can increase the tidal volume in 1 ml per kilo increments, but we're really hoping to try and keep the driving pressure at or below 15. If the driving pressure is high, it's above 15, the first step would be to try adjusting the PEEP upward or downward to see if you could optimize compliance. And if that doesn't work, then you can decrease the tidal volume as permitted by the pH. Again, you're allowed to increase the respiratory rate up to 40 to try to facilitate that. The PEEP can be titrated downward if the plateau pressure target is exceeded, provided the driving pressure doesn't go up. Obviously, as sometimes if the PEEP goes down, the patient de-recruits and the driving pressure can go up. So in those cases, you would put the PEEP back up and then try turning down the tidal volume as permitted by the pH. So these are management decisions that as clinicians you're very familiar with. We're just changing the target slightly. Next slide. Okay, so probably the most novel and challenging aspect of the intervention protocol is the idea of trying to limit the transpulmonary driving pressure during spontaneous breathing, because in usual management of respiratory failure, we're not generally used to trying to control respiratory effort. But here, we're concerned that high respiratory efforts can contribute to excess lung stress and strain. So we need to focus on limiting those high respiratory efforts if they develop. And so we have basically developed a protocol for trying to control high respiratory effort under those conditions. So if the measured lung distending pressure is over 23, then here's what we propose as a stepwise approach to managing the problem. First of all, if the patient's on ECMO, happens to be on ECMO, a very powerful tool for controlling respiratory effort is often increasing the sweep gas flow. And you can increase the sweep gas flow, and often you won't see any change in the blood gas. You'll just see the patient's respiratory effort come down. So that's something to consider. Secondly, you can titrate the PEEP up or down, again, to try to optimize compliance, because what we found in a previous trial is that if optimizing PEEP improves compliance, it'll often also improve respiratory effort. Thirdly, if the lung distending pressure is high, you can try reducing the ventilator support, although often what happens in that context, depending on how sedated the patient is that if you reduce the ventilator support, the patient just breathes more. And so that's a tricky problem, but it's worth trying. The next step is if the main problem is high respiratory effort, then you can try increasing the FiO2, because sometimes increasing PaO2 will reduce hypoxic drive to breathe and reduce the drive and effort. If the patient has a metabolic acidosis, you could consider a bicarbonate infusion. But often in the end, what becomes necessary is an increase in sedation. And this is challenging because a lot of clinicians now have really accepted the idea, and with reason, that sedation is probably harmful, that we want to avoid sedation unless absolutely necessary. And so so it's a bit uncomfortable to start increasing sedation in order to control lung distending pressure. And I think this trial actually offers us a critical opportunity to test the hypothesis that increases in sedation in this context may be of benefit for the patient. We don't know for sure that they are a benefit. This is why this clinical trial is so important. Finally, if the sedation fails to control the high drive to breathe, then you may consider neuromuscular blockade as well. That's potentially effective intervention. Obviously, it's a bit of a setback for the patient, but it's an option of last resort. So in terms of sedation management, it's a little more complicated because we're actually incorporating control of drive with sedation management here. But as a baseline, typically patients should be managed according to guideline-based practice, targeting a RASS of -2 to 0, or daily interruption, whatever your usual practice is. If the dynamic transpulmonary driving pressure exceeds 23, then as we discussed, you can consider increasing the sedation to reduce the respiratory effort and try to achieve the lung distending pressure target. And we suggest that if you're trying to control respiratory effort with sedation, that you use propofol, because propofol appears to be more effective than opioids at reducing the amplitude of the drive to breathe. And so steadily and slowly increasing the propofol is probably the best approach. Obviously patients can have some hemodynamic instability if the propofol is increased too quickly. So it needs to be done judiciously, but that's our recommendation for how to control respiratory effort. That being said, as clinicians, you have a lot of freedom to decide how to manage the sedation in this context. And so we'll be sort of recording and documenting what works. The intervention is applied until any of the following conditions are met. So if the patient dies, or if you reach day 28 of mechanical ventilation, or if they no longer have criteria for hypoxemic respiratory failure. So if they're reintubated within if within the 28-day period they're liberated from the ventilator and then reintubated, then the intervention applies again. If they recover and no longer meet the recovery criteria listed there under number 3, and then they worsen again, then they go back on protocol. So that's basically how the duration of intervention works. If the goals of care are modified so that no escalations of ventilator support are permitted, then the patient would also be deemed to have completed the intervention. Once any of these criteria are met, then clinicians can follow their usual practice and discretion about setting the ventilator, although they're still required to follow the protocol for co-interventions such as weaning. Okay, so we'll briefly run now through the co-intervention management that's specified in the protocol. Co-interventions that we're concerned about are things like weaning, management of severe hypoxemia, etc. These are things that we protocolize in order to avoid any bias in the design related to co-interventions. And the duration of intervention for co-interventions applies until the patient's died, or if they're extubated, or up to day 28 of mechanical ventilation. If the patient's reintubated before 28, then the co-intervention protocol applies again. Next slide. So the first co-intervention protocol is weaning, and we've specified fairly broad criteria for a daily assessment of readiness to wean. And if the patient meets any of these criteria, then we suggest they undergo a spontaneous breathing trial. The spontaneous breathing trial should be conducted according to your site protocol. So if you have a standardized protocol for how you do the SBT, then that should be followed. If you don't have a standardized protocol, then we suggest using a pressure support of 0 and a PEEP of 0 to conduct the protocol, just so that it's standardized in the trial. But if you have a standard protocol at your site, then that's fine too. Prone positioning is required if the PF is below 100, and permitted and recommended if the PF is between 100 to 150, with room for clinician discretion. We suggest referral for ECLS if the patient meets kind of typical Eolia criteria for ECLS intervention. And neuromuscular blockade is permitted only when the PF is below 100, or there's sort of severe refractory patient ventilator dysynchrony that develops. It's not mandatory in this protocol. It's just permitted under those conditions. Inhaled pulmonary vasodilators like inhaled nitric oxide are permitted when the PF is below 100. It's not mandatory, but it's permitted under those conditions. And then we discourage the use of lung recruitment maneuvers based on the best available evidence now suggesting possible harm. Sedatives can be selected according to clinician discretion, and then we went over already the idea that sedation should be managed according to guidelines, with the one caveat where you're trying to control excess respiratory effort in the DPL arm. Next slide. All right, so that's it for me. Maybe I'll stop there and see if